Okay. So we are off and running with neural neoplasms. Faliang, you want to start us out?
Yes, and this I think about the plastic encapsulation of the perineum. I can't distinguish from the two.
Okay, so very good thought. So you're between palisaded encapsulated neuroma and sclerosing perineurioma. When you have fascicles like this with clefts between them, it's PEN, palisaded encapsulated neuroma. So you were correct the first time. Most common place is on the chin and cheek area. Second most common is on the digits. This one looks like it's from the digits, judging by the corneum. So clefts between fascicles of neural tissue is palisaded encapsulated neuroma. The one thing they commonly are not is palisaded, encapsulated, or a true neuroma. But the name stuck anyway. So this particular one is encapsulated. Actually, you can see a little capsule there, but they're often not. Okay. That one's a little pale. We're going to skip that. And this one I can just walk you through. So this is a neurofilament stain on a neurofibroma. No, it's not. This is a leader stain on a neurofibroma, just to show you the number of mast cells that you have there. Anything myxoid tends to have mast cells, and there are tons of mast cells in neurofibromas. In fact, if you ever need a control for a mast cell stain, neurofibroma is usually what we use. So, let's do something a little bit fun. Okay, so
looks very myxoid. It's very large.
Myxoid. Yeah, so do you see attached skin?
No.
Or is it just a large, roundish mass?
Oh, very large, roundish mass.
Encapsulated or not encapsulated?
Encapsulated.
Yep.
So,
And
is this one of the like schwannomas without the Antony A?
so that is one thought, that it would be a schwannoma with only Antony B tissue. That would tend to be pretty edematous across the entire thing. This has edema but also has intact fascicles within it. Never get that in a schwannoma. It's definitely arising out of a nerve. And when you look at it, the whole nerve seems to have exploded like a piece of popcorn in a popcorn popper and become this big, relatively uniform, diffuse thing. So that's more likely intraneural neurofibroma. So schwannomas are intraneural, and the capsule is the old perineurium that becomes the capsule. But neurofibromas can also be intraneural too. Schwannomas, when they're young, have a crescent-shaped zone of subcapsular edema. As they get older, they can be all Antony B and edematous across the field, but usually with big dilated vessels, often hyalinized vessels. This doesn't have dilated vessels. It's not uniformly edematous. It has fascicles within it, and it's more likely an intraneural neurofibroma.
Equal skin, see a dermal neural proliferation.
So lots of nerve, acral skin, vertically oriented. Thoughts?
Neurothekioma?
Neurotheciomas are either cellular or myxoid, and then are pools of mucin with stellate cells.
Oh, it's plexiform?
Looks
Nerve
kind
bubble
of like a plexiform neuroma, but in a bump that's distinctly on acral skin. Anyone?
Oh, accessory digit.
Yeah, supernumerary digit, a nidget. It's a nidget, right? So supernumerary digit looks sort of like an acquired digital fibrokeratoma, except that it has nerve and vessel in it. Okay. Well done. Let's get that guy.
Okay, so there's a pretty well circumscribed kind of myxoidy looking proliferation. I don't really see epidermis.
Is it encapsulated?
It is.
Is it uniformly edematous, or do you have intact fascicles?
It looks like there may be intact vesicles.
So what do you think?
Is this a neurofibroma?
It's an
Sorry.
intraneural neurofibroma. You are correct. And you don't have to be sorry. You're good.
Store form patterns.
Kind of a storiform pattern.
So like the difference like sclerotic fibroma versus like the sclerosing perineurioma.
That's exactly what your differential is. So you've got something that is like layers and layers, like onion skin, and it has a storiform pattern. So it's either a sclerotic fibroma or a sclerosing perineurioma. And how would you tell?
There's a EMA for perineurioma.
EMA would be a really good stain to do for perineurioma. Morning. So you have overlying skin.
Alright, so we have very dense proliferation of cells. Kind of looks like there are pseudovascular spaces and kind of epithelioid cells.
So there are, certainly large cells with abundant cytoplasm.
Oh, okay.
And
I
within
see
the
those big-
cytoplasm, they have these big pink blobs.
So granular cell tumor.
That's a granular cell tumor. So it has granular cell and it has the giant lysosomes. So GCT are about the same color as erector pili muscle. So before immunostains, they were thought to be a smooth muscle tumor. The old name was granular cell myoblastoma, just because they're the same color as erector pili, but they're neural. They're S100 positive.
Looks like a plexiform pattern.
So it's a
ugly.
plexiform pattern, and where are we?
And I think those blue cells.
So what is this?
Looks like gland.
Yeah,
Gland.
parotid, salivary. So you're within a parotid gland, and within the parotid gland, you have this plexiform myxoid tumor, and in areas you can see very wavy neural configuration. So it's not uniform. It is myxoid. You can tell that it's neural. It's plexiform. So what do you think this is?
My differential is because it lacks the background of a diffuse neurofibroma, so I'm thinking plexiform schwannoma.
So plexiform schwannoma is a good thought. Plexiform schwannoma usually will have good Antony A type Verricae bodies. This one, anytime you have intact nerve that's central and surrounding myxoid, it's going to be a neurofibroma. In a schwannoma, the only thing that proliferates is the Schwann cells. the nerve trunk is squashed over to the side. So it's always plastered up to the capsule on one side in a schwannoma. Whereas in a neurofibroma, the whole thing pops like popcorn. So the intact nerve can be anywhere in there with myxoid around it. So plexiform neurofibroma, you're correct that we don't see a background of diffuse neurofibroma. It could potentially be sporadic. If it's sitting in the parotid, the patient probably has von Recklinghausen's neurofibromatosis.
They could be sporadic without the background of diffuse neurofibroma.
When you have a background of diffuse, then you absolutely know that it's loss of heterozygosity in the setting of von Recklinghausen's.
Okay.
Even without that, it's usually von Recklinghausen's. Most plexiform neurofibromas are. Okay. So Zhufeng, you get to pass or play. So do you want to
回答
answer?
还是不
So how do you say pass or play in Chinese?
玩还是
回答还是不回答？你
Pass
还是回答？就是你回答你的答案，回答答案。
Pass. Pass is okay. Okay. So Aliang.
哎
So first off, the overlying epidermis, is it attenuated, effaced, or is it
I
acanthotic?
consulted.
Acanthotic, so name a few tumors that produce acanthosis over the tumor rather than effacement. Can you name 3? So-
speed,
So dermatofibroma,
speed,
so not DFSP, which effaces, but DF, so
Yeah.
dermatofibroma,
speed,
Spitz-Nevis, and the third one is in the neural chapter and is GCT, granular cell tumor.
GCT.
So, 3, big clue is having a tumor. A tumor will normally stretch the epidermis, thin it, efface it. 3 break that rule and have acanthosis instead. Dermatofibroma, Spitz-Nevis, granular cell tumor. What's in the dermis is about the color of a rector pili muscle. That would mean it's a GCT.
They deep like this usually almost looks like it's at the fat or going to the fat.
Oh yeah, it can go as deep as it wants to go. So, but the clue at scan, even before you look higher at the lesion, is acanthosis overlying. So if you have overlying acanthosis, 3 tumors that will do that: dermatofibroma, Spitz-Nevis, granular cell tumor. This one is the color of a rector pili, so we're suspecting granular cell tumor, and in fact when we look higher it is in fact granular, and it has giant lysosomal bodies which you can see sitting in vacuole like that one right there. Okay, so that defines then a neural granular cell tumor. They're non-neural granular cell tumors as well, but those A, do not have overlying acanthosis, and B, don't have giant lysosomal granules.
So it looks like we're on acral skin.
Acral skin. What's this stuff?
So it looks like nerve fascicles. with
Nerve
clefting.
fascicles. So you're on acral skin with a bump with nerve fascicles and vessel.
So palisaded encapsulated neuroma.
So
Or-
is
oh,
this
is accessory digit.
an encapsulated thing, or is
Yeah.
this random nerves?
Random nerves.
So this is
Accessory digit.
accessory digit, supernumerary digit, nidget, whatever you want to call it. So what is that structure right there?
The there's a fire.
A rector pili.
Everything is looking good.
and everything is kind of the same color.
And a little bit acanthotic. Epidermis.
Say it again.
The epidermis is a little bit acanthotic.
Epidermis is a little acanthotic, so a little acanthotic over a tumor that's the color of a rector pili muscle.
Granular cell tumor.
Granular cell tumor, even before you look higher at the granular cells. Now this one has an inflammatory infiltrate that's kind of nodular, right? Suggesting the body doesn't like this one. I'd look carefully for mitoses. I'd look at proliferative fraction, because big ones you know are malignant. Smaller ones can be malignant, so I'd look for pleomorphism. I'd look for Ki67 proliferative fraction. If it has nodular lymphoid aggregates, it means there's a host immune response to it, right? Which can be a clue to a malignant granular cell tumor.
Oh, mixoid.
It's a little mixoid.
You can maybe
Some of the cells are wavy.
thinking like a neurofibroma.
Yeah, like a neurofibroma, but then you have pleomorphism. You have bigger, darker ones, right? So then this is malignant neurofibroma?
Not just that alone. You can have that in the nerve cells. I think it's more
Exactly.
mitoses and like
So you are absolutely correct. So mitoses mean absolutely nothing in neural crest and I'm sorry, I said that wrong. Atypia means mitoses do mean something, but atypia alone in neural crest or smooth muscle neoplasms means nothing. So in the smooth muscle world, you call it symplastic leiomyoma when it has high-grade atypia but no mitoses, and they're benign. And you call it ancient change in neural crest things. So in melanocytic and neural, you call it ancient. In smooth muscle, you call it symplastic. It's the same thing. It just means you have big, dark, atypical cells sitting in an otherwise benign neural crest lesion. Means nothing. They're benign. So you don't lose your wits over a few big hyperchromatic cells.
I think this is another granular cell tumor.
Okay, you were a little slow, but that was very good. That's about how quick you want to nail them. So this one, acanthosis, maybe a little bit, hard to tell. Certainly is the color of a granular cell tumor, right? And then you just want to look, number one, how big is it?
Big.
So when I was a first-year derm resident, the rule was if it was 8 centimeter or bigger, it was malignant. Then the rule changed to 5. Then the rule changed to 3. Now they're talking about 2. That means these things have a nasty habit of metastasizing, and our cutoff keeps changing. Look for pleomorphism. Look for mitoses. Look for host response. This one has no host response. It's not that big. It's going to be benign.
So kind of like a diffuse proliferation, wavy spindle cells.
Yep.
Thinking probably a neurofibroma.
Yeah. What are all of these things?
So fat cells, just kind of degenerated or
Either fat cells, which you can occasionally get in
senescence.
there are neurolipomatous hamartomas, but they usually have mature nerve in them. This you can get, like in a nevus, you can get fatty change in an old neurofibroma. Sometimes it's also that those aren't real lipocytes. It's a fake out. It's just blebs from the xylocaine that you pumped in too fast.
So this is a deep proliferation. Or are we focusing up here? That looks like it might be a Verrucae body.
That is one whopping Verrucae body, right? So it's palisaded around that pink acellular stuff. So these are all Verrucae bodies, right? And Verrucae bodies you usually associate with schwannoma, but they can also occur in neurofibromas. And if it's superficial and non-encapsulated, it's a palisaded neurofibroma. If it's deep and encapsulated, round to oval, with a crescent-shaped zone of subcapsular edema, then it's a schwannoma.
I think this is neurofibroma.
Neurofibroma.
Without capsule.
And then what's all of this stuff?
Gland, sweat gland.
Sweat gland. Looks syringomatous. So there are syringomatous schwannomas and syringomatous neurofibromas, and they're benign. But you get this crazy proliferation of what looks like syringoma all through the neural tumor. They're rare, but they are totally benign. Have to be distinguished from Triton tumors. So, David, what's a Triton tumor?
Triton tumor, isn't it have to do with rhabdo, like a skeletal muscle tumor?
It's skeletal muscle differentiation.
Plus neural.
And is it benign or malignant?
Malignant.
Malignant. So it's
PNST with rhabdoid differentiation.
exactly. So it's a malignant peripheral nerve sheath tumor, MPNST, with rhabdoid striated muscle differentiation, and they're malignant tumors, and they look like what's a Triton?
A lizard.
Oh, you are correct. It's a salamander. And when you cut off a salamander's tail, it regenerates a tail. And when it regenerates a tail, you get this bundle of primitive nerve and striated muscle as it's regenerating its tail. So the Triton tumor, the malignant peripheral nerve sheath tumor with rhabdoid differentiation, is named a Triton tumor because it looks like the regenerating tail of a salamander that you chopped off. Oh, pass. Okay. Pollyann.
I see the Merkel cell.
Merkel. Very good. Why is it a Merkel?
It's blue. It's chromatic. Pepper.
Hyperchromatic blue, and it is trabecular.
Trabecular, yes.
So it looks like trabecular bone where you have these interlacing walls. So it has a trabecular pattern, long parallel theques that interlace like trabecular bone. And it's smudgy blue cells, so it's likely to be a Merkel cell carcinoma. Which kind of bridges between neural and epithelial.
Or superficial, large nodules.
Is it a single nodule, or does it have multiple nodules? Multiple nodules, myxoid cells. What kind of things might you think of?
A myxoid neurothekioma.
Like a myxoid neurothekioma. So they're stellate cells. If it's strongly S100 positive, then it's a myxoid neurothekioma, also called nerve sheath myxoma. So nerve sheath myxoma or myxoid neurothekioma is individual islands or pools of myxoid cells with stellate nuclei.
So we have a blue tumor.
You have a blue tumor, And this one is not so clearly trabecular in pattern, right? So give me a differential for this kind of...
So we have the lemon mnemonic, lymphoma,
Okay.
lymphoma, neuroblastoma, melanoma, Merkel cell.
Very good. And it's, it's handy to have a mnemonic for things. Small cell endocrine neoplasms can fall into that group of small. Ewing's sarcoma fits into it. So next step would be immunostaining and also age demographics. Neuroblastomas, most of them are kids.
Clefts.
So you definitely have clefts. The whole thing itself, is it...
Would it be like, it's a little deep. I was thinking like PEN or maybe cellular.
Yeah, it looks kind of like a big palisaded encapsulated neuroma, right? It definitely has Verricae bodies in it. It is oval. It has a little crescent-like zone of subcapsular edema here. It's a schwannoma.
Very purple.
Very purple. Some might say blue.
Yeah.
Zonal necrosis, suggesting it's malignant and outgrowing its blood supply.
Small round blue cell tumor.
Small round blue cell tumor. Give me a differential.
Lymphoma, Ewing sarcoma, melanoma Merkel cell, small cell cancer. But it's pretty trabecular pattern.
Yeah, this is pretty trabecular, so it's less likely to be a Ewing's or a small cell lung or any of the others. More likely to be a Merkel. Most of the ones you see in skin are Merkel. How do Merkels behave?
Badly.
Badly. So there's some evidence that if you are Merkel virus negative and associated with a squamous cell carcinoma, that it's even worse. But Dr. Pollack was always fond of saying, because there are always new stains to predict the outcome of Merkel, and he said the worst prognostic factor for having Merkel cell carcinoma is having Merkel cell carcinoma. Basically, there are no good outcome Merkel cell carcinomas. Okay, these things are why you aren't allowed to stack the slides, because you get this, the cover slips scratch.
It's pretty encapsulated. Maybe a little bit of subcapsular edema, exiting the schwannoma.
Yeah, so it's either going to be a neurofibroma or a schwannoma. If you needed to tell the difference, how would you tell the difference?
You could stain it for neurofilament.
Neurofilament, and what would you see in a schwannoma?
Absent staining in the tumor and the NF, because the neurofilament on the edge, and then NF would have the neurofilament like all throughout.
Yeah. So in NF, there are random linear neurofilaments just spread throughout the whole thing, where the whole thing became popcorn and kind of pushed those apart. Whereas in a schwannoma, you usually see no neurofilaments at all in the bulk of the tumor, and you may see the compressed nerve over right under the capsule on one side. So that's absolutely correct. Okay, what's this one?
So this is pretty superficial. It kind of looks like it's onion skinning
Yep,
to me, so perineurioma.
yep, sclerosing perineurioma. And what stain would you get for confirmation?
EMA.
Yep, epithelial membrane antigen is a good one to do for that.
Multiple nodal a little onion skin.
So this
whorl.
is
So this is another perineural.
this is another sclerosing perineurioma. Those onion skin whorls are the giveaway.
Perineuroma are always sclerosing. There's a
No, they're not always sclerosing, but the ones we see in skin, 99% are sclerosing. So there are soft tissue perineuriomas that are not sclerosing, but we rarely see them in skin. The ones we see in skin are almost always sclerosing. Okay, so Falion, your turn.
they fused the tumor and can I use a high power?
No, because the answer's at this power.
Oh yes, it's schwannoma.
So it's capsule, subcapsular edema, so probably schwannoma. There are some still fascicles within it. You might consider an intraneural neurofibroma if you wanted to tell the difference. You get a neurofilament stain.
Yes.
And in the schwannoma, you have no neurofilaments, maybe a nerve trunk squashed on one side, and in the neurofibroma, they're spread throughout.
So it looks like a single myxoid nodule, like a neurofibroma.
Yeah. So neurofibroma, very good. They tend to be pretty. Sometimes they have fascicles in them. Otherwise, they're very even cellularity, like this, all the way across. Loose, myxoid, very uniform across the field. So you've got muscle, you've got fat, and then you've got this mass here. Of little fascicles, of wavy cells, sort of in bundles, haphazard, all over the place.
I was thinking maybe plexiform with a diffuse neurofibroma.
So plexiform with diffuse, the diffuse would be everywhere, which we don't really see. And these are in really well-defined fascicles, although they're haphazard. So more likely, anyone? Traumatic. True traumatic neuroma. Okay, let's see. Okay, how about this one?
Pretty well-defined nodules in the dermis.
And are they all round or are some linear?
Some of them.
Suggests that they're cut in different planes of section, right? That these are like long worm-like things, some of which are being cut lengthwise, some of which are being cut across. And then, what's its background here? Is that normal dermis?
No, I'm thinking, is it like a plexiform arising out of a diffuse?
So it's a plexiform embedded in a diffuse neurofibroma. And so that means what?
They have NF1.
NF1 and loss of heterozygosity. So it's a monstrous segment in someone with NF1 where they have no tumor suppressor allele anymore. So if normally you have two alleles. If you're born with neurofibromatosis, you only have one allele. You knock that out sporadically. Now you've got no tumor suppressor gene at all, and all hell breaks loose, and you've got this big, massive segment that is brown because it's all a big cafe au lait, and it's bumpy and feels like a bag of worms because there's diffuse neurofibroma, and embedded in that is plexiform neurofibroma. It's like everything you can get in neurofibromatosis is there because there's no tumor suppressor gene at all, because you were born with only one allele and you sporadically knock that out. So how common is that sporadic mutation of NF1?
Very.
Very. So if you look at your average patient with neurofibromatosis with von Recklinghausen's, and you count every neurofibroma on their body, that's the number of mutations that you have right now on your body. Why are you not covered with neurofibromas? Because you were born with 2 alleles, right? They were born with 1 allele. You have to be careful always what finger you put down. They were born with 1 allele. And then every neurofibroma they grow is a second sporadic hit, just like is happening on your body. The mutations in neurofibromin is the most common mutation in human beings. We're covered with them. And most people have so many of them that they happen just by chance to get 2 at the same spot, and then they grow a little sporadic neurofibroma. Right? Every sporadic neurofibroma has no neurofibromin, has homozygous loss, but it's just sporadic. You are covered with them. You happen to get 2 that hit in the same place. Those people will get 1 or 2 during their lifespan, right? If you were born with only 1 allele, then every sporadic hit becomes a neurofibroma. If you lose your remaining allele prior to, in fetal life, then you get a segment with loss of heterozygosity.
Excuse me, so the sporadic neurofibroma, the men still have 2 alleles, and they both silent at the same time,
Correct.
sporadically.
Sporadic. So you took a hit, you're constantly taking mutations all over your body. You take all sorts of hits, and then a second one happens to hit same cell.
Thank you. Got it.
Right.
Better.
And so that's when you grow neurofibroma. But if you assay any neurofibroma, there's homozygous loss. Just like in sporadic sebaceous adenoma, if you assay it, you're probably going to find microsatellite instability. Doesn't mean they have Muratori syndrome. It's just double hits. It's sporadic loss, just like growing a neurofibroma. That's why we no longer are. I think we should no longer test for that because it makes no sense.
So some of these, they look like almost nests of like epithelioid.
Yeah,
cells.
epithelioid nests.
In this chapter, it makes me think of like a cellular neurothekioma.
In this chapter, it makes you think of a cellular neurothekioma. In other chapters, it would make you think of plexiform fibrohistiocytic tumor. Can be similar. They may be the same tumor. So cellular neurothekioma may be the same as plexiform fibrohistiocytic. I'm sorry, Shirley, what else did you mention?
I mentioned the Spitz.
Oh, Spitz.
Can
Yep.
be in-
Spitz can also be in the differential for it. This one, though, seems to be making collagen. Now, Spitz can too. Spitz can be desmoplastic, so that's also a very reasonable thought. Spitz would be S100 positive. Cellular neurothekiomas are S100 negative. But they're S100A6 positive, just like anything histiocytic would be. Let's see what here. Okay, David, where are we?
Scalp, or it's a dog.
Scalp or it's a dog.
Probably scalp.
Yeah, probably scalp. One of the hints is they're eccrine glands, right? Do dogs have eccrine glands?
No.
No.
Nope,
can't
only
slide.
primates. Only primates have eccrine glands, right?
That's why they pants.
So if you biopsy a palm on a koala, Koalas have apicrine glands on their palm. So they're, why does horse sweat stink? Because it's apicrine, right? The ecrine is purely primate. So we know that this is a hairy primate of some sort, right? Probably human scalp. And then, what's going on in this human scalp?
Little nodule, kind of round, nervy-looking cells.
And they're kind of nondescript epithelioid in little clusters.
It's like myxoid areas. The myxoid neurothekioma.
Yeah, myxoid neurothekioma is a thought.
There's a nerve maybe next to it. It's like an old schwannoma.
But it's not really encapsulated,
Yeah.
right? Likelihood with this being on the scalp is it's some sort of heterotopic glial tissue, right? Often they have aplasia cutis over them. If it's a fully developed meningocele, you've got all those vascular-like clefts and the wrapping around collagen. This just looks like it's probably just heterotopic glial. You're halfway to an encephalocele, basically. And then this one, where you have skin, and then you're down in here, and you have these kind of similar but much larger.
Looks like a glioma.
Yeah, so glioma is reasonable thought. This one's beyond glioma. This is brain. So this is true encephalocele that was cut into.
Oops.
Now, if it's ectopic, which this was, didn't connect, as far as we know, you don't lose anything when it's cut out. But if it connects, then you just did a partial lobotomy. Right? Midline congenital lesions need imaging studies prior to surgery. Right? You would rather not see brain on the path report after you have done surgery of a midline lesion.
So, Professor, this is an intracranial gland, glioma.
That is a
Intracranial.
so that is extracranial. So it's extracranial. It was in skin, and it's ectopic brain, which is a step beyond glioma.
Not nasal glioma. Nasal.
No, not nasal.
So,
Scalp.
just
And-
different location.
Different location is a clue. Correct.
So the patient will lose some function of his brain.
If it connects. If it doesn't connect, it was just sitting there. Maybe it was sentient by itself, but not connected to your consciousness. So you may just have excised a separate sentient being, unlikely.
Oh boy.
If it's ectopic, no harm is done. If it connects to the rest of the brain, that would not generally be good. If you are working on a congenital midline lesion and every time you pull the eyes bug out, stop.
Stop. Dangerous.
Okay. So what do you see here?
Of my turn, I'm sorry. Very superficial nodule, non-encapsulated, very cellular with cleft inside of tumor.
And so is it clefts between well-formed fascicles, or is it closer to onion skin or plywood?
Close to onion skin plywood.
So what might you want to look for?
I will do an EMA.
Yeah, so this could be a neurofibroma, that's just a little plywood-like. They're called thumbprint neurofibromas,
Oh,
right?
fine.
Or it could be a sclerosing perineurioma. So if it's S100 positive, it's a neurofibroma. If it's EMA positive, it's a sclerosing perineurioma.
Looking for mast cells will help a lot.
Looking for mast cells will help a lot because the sclerosing perineuriomas do
No.
not have them, and the others, the neurofibromas, tend to have a lot. So, very good. Okay, how about this? Based on color alone, what is this?
CCT.
GCT, granular cell tumor. It's been described as the same color as erector pili. You can see the erector pili there. It's the same color. Other people have said it's the color of everything Barbie owned.
Usually ropey, usually too. Is that something?
Say again?
The ropey collagen.
Ropey collagen trapped in it is common. Yeah.
Maybe it's so the rocky collagen, normal collagen, not sclerotic collagen.
Normal collagen, not sclerotic. Correct. Normal, not newly synthesized, just normal collagen. Okay, this is what? Lymph node.
I was like, I see.
And then subcapsular spaces within lymphatics is always where you're going to look for metastasis.
Okay.
And in this case, the metastasis is something that's small blue smudgy cells. This is sentinel node positive Merkel.
How about the neuroblastoma? Can it be exist?
Yeah, so neuroblastoma, you will see in fellow unknowns, you will have lots of neuroblastomas to look at when we do fellow unknowns. It's a small blue tumor. Often you get squashed cells, so-called carrot cells, that are sort of linear, carrot-shaped.
They metastasize to the skin a lot. Blastomas.
Neuroblastomas can metastasize to skin. This year we had a little kid with a heel nodule that was metastatic neuroblastoma. So we definitely see it. It's a kid, it's a small blue tumor, you've got squashed carrot cells, it's probably going to be neuroblastoma. And unfortunately, when we see it in skin, it's already metastatic. Okay, so this is another scalp, another kind of weird, loose, myxoid area, and so it's probably heterotopic glial tissue again.
Let's get
So we got a big mass here. And when you look at it, there is striated muscle. And the striated muscle is kind of random between collagen fibers, right? So it's not organized the way muscle normally would be, right? It's between collagen fibers, that striated muscle, and then you have a myxoid, kind of neural-looking tumor with an expansile growth pattern. So, David, what do you think this might be?
Triton tumor?
This is a salamander. No, it's not. This is a malignant Triton tumor from a patient, but it looks like a regenerating salamander tail. Okay. Okay. So, what do you think? Tell me about the epidermis.
Whose turn is
I
it?
don't know.
I can do it.
Sure.
Or it looks.
Yeah. So GCT, there's massive pseudoepitheliomatous hyperplasia over it, right? Very easy to have that misread as invasive squamous cell carcinoma. What's a common place for granular cell tumor? Tongue, right? And there are lots of people who end up getting radical necks for a completely benign granular cell tumor because the initial biopsy was misread as invasive squamous cell carcinoma. So squamous cell carcinoma on the tongue, oral mucosa, you always want to look, are there granular cell tumors between the squamous islands? Because you don't want someone going for a radical neck for a benign granular cell tumor of the tongue. That and necrotizing sialometaplasia are the two big mimics in oral mucosa, and warty dyskeratoma. I guess those are the three big mimics. Warty Ds are crateriform tumors on the usually alveolar ridge that you've got to recognize the acantholytic dyskeratosis and the fact that it's not a squamous cell carcinoma. Don't cut the jaw out. Granular cell tumor, massive PEH, necrotizing sialometaplasia. There was a U.S. president who had his palate excised for squamous cell carcinoma. It sits at the AFIP museum. It is benign necrotizing sialometaplasia. He had a plate replacing his palate for the remainder of his life. And apparently food kept going up into his sinuses and things. Okay. We've got 5 minutes. And in 5 minutes. Okay. What do you see here?
I see a large nerve vesicles superficially. The dermis.
Okay, so what do you think?
It's endothelial sheath neuroma or plexiform neuroma.
So, yeah, probably. So it could be a traumatic neuroma, but I see no evidence of trauma behind it. Some areas are becoming a little more myxoid, so it's probably a plexiform neurofibroma. You want to be very careful when you make that diagnosis. Make sure it has the neurofilaments in it the way you'd expect, like a neurofibroma, because you don't. When you make that diagnosis, you're essentially labeling someone with von Recklinghausen's. So.
Very deep.
Very
No
deep.
attached skin. I think in schwannoma was my first.
So schwannoma is a single round to oval thing that's encapsulated. This has lots of individual things embedded in a myxoid,
Like the last plexiform.
like someone with von Recklinghausen's and plexiform neurofibroma. Correct. Let's see.
So, pretty low circumscribed.
Yep.
Dermal mass.
Vertically oriented.
Mm-hmm.
Some clefts between the fascicles.
I think PN.
Palisaded encapsulated neuroma. Very good.
Look at diffuse NF, but I'll make sure it's not like an NPNST.
So diffuse NF or intraneural NF? Probably intraneural NF. See how it looks like it's a linear worm that became fat? It's a fat worm or caterpillar, right? And then, looking closer, MPNSTs rarely would keep the configuration of a nerve.
So this is really superficial.
Yep.
It looks like it's onion skin,
Yep.
so it's perineurioma.
So
sclerosing.
probably sclerosing perineurioma. Very good.
There's cleft.
Clefts, but onion skin.
Okay.
So concentric.
Yes.
Let's see. What's that?
A solitary nodule with cleft inside, maybe. This is PN, I think.
Yeah,
With
probably.
some
And
volume.
PENs often shell out like that when you take them out. Okay, and with that, we are done. Well done.
Thank you, Dr.
Thank
Elston.
you.